talk about De Winters. De Winters is another important topic that is probably not well taught in many institutions. And we need to let me start by telling you about this patient. So he's a gentleman in his 40s. He comes in with chest pain, gripping the left side of his chest. He's sweaty, he's pale, he's clammy. Classical patient where you'd expect that the ECG should be a classic STEMI. And we run an ECG, but there's no ST elevation. And you can hear a few people already saying, a few colleagues already saying, could it be anxiety? Could it be gastritis? Maybe it's just having reflux. He's too young to have a heart attack, which, to be fair, it is, you'd expect a heart attack in an older person with a lot of cardiovascular risk factors. But, occasionally you do get a young person with a heart attack. So it's always good to keep our eyes open. And so the 5 minutes later, an ECG was ready. Of course, we were still waiting for TROPS. And what did we find? What did we find on the ECG? There was no ST elevation. Instead, what we found were gigantic T waves. The ST segments were not rising. Instead, they were sloping downwards. And I'm going to show you this ECG in a second, right? But get it, in terms of clinical context, this particular gentleman was presenting classically. In terms of the ECG, no ST elevation. And I will show you the ECG. But why? And this is the ECG, to be fair. You could see that this is not a particular ECG, but this is a similar ECG. And what you will find is that there's an ST depression in V2, V3. You could see there's not so much ST depression in V1. And I usually ask people to use a ruler, to put a ruler across their J points to see if indeed there's an ST depression. And here you can see, if I expand the screen and erase, you will find if you go across your ST segment, your J point is much lower. So there's ST depression and there are these gigantic T waves. But to understand why this pattern is so dangerous, you need to understand the blood supply of the heart. I find that it's often easier that way. So think of the heart, I'm just going to permit me to draw my version of the heart, right? So let's assume this is the heart. And, with all the big vessels, right? And with all the big vessels. So from the base of the aorta comes this left coronary artery and then the right coronary artery. So let's say this is the LCA and this is the RCA. Now, the left coronary artery is where we want to pay a bit of attention. Now, the left coronary artery branches off to the circumflex artery, which goes to the side of the heart. And the left circumflex artery can also give rise to the left marginal artery. But that's not where we are going to. The left coronary artery has branched off into the circumflex. Pardon my French. But it also gives off the left anterior descending artery, which then goes on to give the diagonal arteries. And so this is the entire anterior part of the heart. The left anterior descending artery supplies the anterior aspect of the heart, part of the septum, and of course the apex of the heart, as you can see that I have circled here. And so what we need to know is that the left anterior descending artery is the star of this video. This is the star of this video. And it supplies the entire front wall of the heart. It's the engine of the heart. If this blood vessel stops flowing, the pump loses its strongest muscle. So now let's go back to the ECG because De Winters has a fingerprint. Now, we talked about the fact that you get this down end slope rather than the up sloping that you will find in a classic ST elevation. And these T waves are enormous. They are smooth, as you can see. They're smooth, they're wide, they're angry. Then also something important that you will find here is there's no R wave progression. Yes, no R wave progression. As you can find, you expect a proper R wave progression as you go from V1 to V6. But what do you find? No R wave progression here. So the R waves disappear, basically. You can't find, any R wave as you proceed. And then many times the AVR pops up, and which will be a warning sign of proximal left anterior descending artery occlusion. So here's the most important thing in this entire video. The Winter is a STEMI equivalent. That means the left anterior descending artery is blocked 100%. Right? So you have a plaque on the artery, plaque formed over loads of years of maybe poor lifestyle habits or vasculitis, and then a clot is formed causing 100% occlusion. Blood is not getting to the heart. And this is dangerous. When no blood is supplying the anterior part of the heart, that part of the heart cannot pump blood. What do you expect? Arrhythmias, ventricular fibrillation. This person is minutes away from death. So this patient needs the cath lab immediately. The same urgency as you will give a classic ST elevation is what you will give here. And many people often confuse the Winters with Wellens, but they're kind of opposites, because Wellens is not a STEMI equivalent. It's the left anterior descending artery critically narrow. So in Wellens, this is the Winters. But in Wellens, what you have is the plaques are formed. There is a clot, but there is still some blood supply. It's just maybe 80 to 90% blocked, but blood is still reaching the heart. Wellens is warning you of an imminent heart attack. You shouldn't send the patient home. You should not stress test. You should still inform the cath lab. But the Winters needs immediate PCI because the left anterior descending artery, the LAD, is fully occluded. So Wellens, it's like a whisper, but the Winters is a scream. So in the Winter syndrome is a STEMI. There is no observation period. There's no repeat ECG in 30 minutes. This is not gastritis. This is not anxiety. You call the cath lab now, and then you activate the STEMI pathway. You call at cardiology, and just as a brief summary, what have we discussed today? So as a brief summary, we've discussed that in your De Winters, you will have upsloping ST depression, as you can find here. Upsloping ST depression. You will find giant broad T waves. You will find loss of R waves. Right? Loss of R waves. And then you will find that the LAD is fully blocked. This is a STEMI equivalent. It requires immediate cath lab activation. Right? The Winters does not look like the STEMI that you were trained to recognize. But once you know the pattern, you're saving the anterior wall of the heart before it's too late. Let me know if you found this helpful, and see you in the next one.